Morning everyone. So like Stuart said, I'm just going to change the tack a little bit and try and talk a little bit about some advice for patients, more so patient-focused advice on how to manage oral health in chemotherapy and radiotherapy. So in today's talk, I'm hoping to discuss 4 main topics. One is the oral side effects of treatments. The second is some practical advice to follow before, during, and after treatment. I also want to touch briefly on how treatment changes the treatments dentally that we can have. So some treatments like tooth extractions do change a little bit after you've had cancer treatment. And then I'll talk a little bit about the take-home message. So I just want to start us off with a few images on some oral side effects that you can and sometimes you don't see. So this advice is not a one-size-fits-all. Some people will experience some things and other people just won't. But the important thing is if you're aware of what to look for, you can then seek care if you need to. So some of the common side effects. So oral mucositis is what we saw in the previous slide. It's characterised by painful sores and bleeding in the mouth, and it usually affects the soft tissues of the cheek, the tongue, and sometimes the inner lip. It can lead to difficulty eating, talking, and if you wear dentures, the denture-bearing surfaces tend to become inflamed and it can be very uncomfortable to wear them in day-to-day life. The other thing to be aware of is oral thrush. We all know about thrush, but when it manifests in the mouth, it can sometimes be symptomatic and sometimes be completely asymptomatic. The thing to look for is white patches or white and red speckled patches on the soft tissues of the mouth. And if it is symptomatic, you can expect some burning, some soreness, and again, the difficulty eating and speaking. Dry mouth is another really common side effect, and it affects a lot of people who are having cancer treatment. The issue might not seem as problematic as some of the other things we saw, but dry mouth can be a problem long term because saliva is amazingly protective to our teeth and tissues. And without that, we're in a very, very high risk category for getting decay. Tooth decay tends to affect patients who have particularly radiotherapy in the salivary gland region, reduces that saliva production significantly. And again, like the other 2 issues, difficulty in speaking and eating is a common result of dry mouth. It's really important though to look at these issues and making sure that if you are having difficulty eating, it's important to raise that with your healthcare provider because you don't want to be in a situation where you're not getting the nutrients you need as a result of these side effects. Another common side effect is bleeding gums. So more so than the odd bit of bleeding, it's more like every time you brush, the gums are bleeding quite a bit. And this normally happens during treatment more so than as a prolonged side effect. So it will generally resolve after treatment is complete. But if you're noticing that the bleeding is happening in a chronic way, that can become a problem and lead to tooth loss. So it's important to flag this with your healthcare provider if you're experiencing prolonged bleeding. Eating also changes. So food tastes different, sometimes bitter, sometimes metallic. And you can have difficulty swallowing, opening the mouth fully because of the muscles being affected. And sometimes those inflamed oral tissues can react to certain types of food. So you might have to modify the diet to work around that. It's sounding a bit doom and gloom, but there are options. I will get to that. So, strategies. What can we do? This is an ideal situation, and I know that not everybody is going to be in a situation where they can make time to go and see the dentist before treatment, but if you have started treatment, it's still not too late to just touch base and work out what strategies can we employ. Seeing your dentist before treatment is really, really a good idea, so you can have a plan in place and have a good check to identify any issues that are happening before you start treatment. And the reason I say this is because a lot of times tooth issues don't necessarily hurt until you're in that end stage and things are really not going well. So an absence of pain isn't an indicator of health. The important thing in this before treatment phase is to identify whether you've got disease in the mouth, broken teeth, chronic infections that aren't hurting you at the moment, and address them before your immunity dips during treatment. Oftentimes, when your immunity dips, these chronic infections will flare up, and the last thing you want is to be dealing with an acute tooth issue during treatment. The other thing, which I'll speak a little bit about later, is tooth extraction. In some cases, when I assess patients prior to starting treatment, we have to have that discussion of this tooth is probably not your strongest tooth, and even with treatment, its success rate might be low. Do you want to consider having the tooth removed before we start treatment? And the reason for that is after treatment is complete, even for many years afterwards, having a tooth removed has a significant risk associated with it because of the way the bone has changed. So we'll speak a little bit about that later on. During treatment, what can we do during treatment? The important thing is to check your mouth yourself when you're doing your brushing every day. And if you notice white patches, red patches, bleeding gums, it's important to flag that with your healthcare provider. What about dry mouth? Dry mouth is a nuisance at best and problematic, very problematic at worst. So it's important to try and keep the mouth moist. Sometimes that means sipping water throughout the day, or if you can tolerate sugar-free gum, you should try and stimulate your own saliva production by chewing. Another great product or products to use is artificial saliva mouthwash. Now, I'm not affiliated with a company, I just want to say that. But in my professional experience, there are a few good companies out there such as Biotine and Oral 7 that have a whole array of products that are helpful for dry mouth. The main thing with these products is because they're artificial saliva, they don't last very long, and you might find that you need to be using them a few times a day, particularly if you're going to be speaking a lot, or if you're going to be exercising or doing any kind of aerobic activity and the mouth is getting dry. The important thing to consider is avoiding things that are going to make a dry mouth drier, such as smoking, alcohol, and even caffeine. What about difficulty eating and swallowing? A lot of patients come and say that they're having trouble eating, and we really need to address that because you need to be keeping your nutrition up. So one good thing to consider is some tweaks to the diet, trying to have moist meals. That doesn't always mean just soup. So you can look at soft food that's got gravy, sticking to things that are not spicy and not going to be sour and irritate already inflamed tissue. And keeping the mouth clean. So this is where it's so important to have that oral health care plan, because as a dentist, my job is to assess which needs I need to be covering off so that my patients don't come out of treatment with a whole host of dental problems. So keeping the mouth clean and doing it in a way that's not going to involve a serious regime every day, keeping it simple and effective. So what does that mean? Having some kind of fluoride product. So in Australia, generally all fluoridated toothpaste is about 1,000 parts per million fluoride. And maybe looking at something like a high strength toothpaste, for example, I've got here Nutrifluor 5000, which is one type of high strength toothpaste. That is about 5 times stronger than what you can buy in the shops. And it's that added defense that you really should be looking at, because when your mouth is dry, you're open to getting lots of decay. So if you can boost your own defense by doing something simple, like swapping your toothpaste out, it's a good idea. It's not for everyone. You want to make sure that you're not leaving it around kids and not leaving it around anyone who's pregnant or breastfeeding. But for most cases, this is a good sort of adjunct to your normal cleaning. The other thing to consider is when you're using Nutrifluor or any toothpaste, if you're using a strong toothpaste or a basic one, spitting and not rinsing is really important for that toothpaste to sit on your teeth and form a protective film against decay, right? Another good tool is a ultra soft toothbrush. So I think my personal opinion is hard toothbrushes just belong in the bin anyway. So medium, use that for cleaning grout and stuff. Soft is what you want to be using in your mouth, right? Ultra soft is also an option, and particularly if you have got inflamed and bleeding gums, sometimes even soft bristle brushes are going to strip those gums, and you want to be aware of that. So my go-to toothbrush that I recommend for my patients who are starting cancer treatment is a Curaprox brush, not affiliated with a brand, it just works really, really well. So it's a very, very soft brush that has a lot of thick bristles, and they tend to not aggravate bleeding gums, so really important. Still very effective at cleaning and striking that right balance. The other thing, as I mentioned, is dry mouth products. So you've got sprays, you've got gels, you've got mouthwashes, a whole array of dry mouth products, which are fantastic for symptomatic relief. The important thing that I haven't mentioned here is mouthwash, and my personal opinion on mouthwash is that if it's medicated and used for a particular purpose, great. But in general, I prefer not to use it because it will wash away that toothpaste that's stuck to your teeth and protecting the teeth. So if you're going to rinse your mouth, you want to be rinsing, particularly after meals, to wash away any food debris that's stuck on after meals. A good rinse to make at home is a bicarb salt mouthwash, and the two key factors there is the salt is antibacterial or antiseptic in a way, and it reduces the bacterial load, and the bicarb cancels out any acid, and acid is what really causes decay. So having that bicarb in there is just keeping that acid level low. If you are going to use a mouthwash, stick to alcohol-free again to avoid that drying aspect of alcohol. So after treatment, what can we expect after treatment? Dry mouth is really one of those things that lingers, and it stays on even maybe many months or years after treatment. And this is that coming back to that risk factor again. So if you previously had fantastic teeth and then after treatment you've had a bit of dry mouth, that risk level of you getting decay will have changed. And it's so important to keep some strategies in place to prevent yourself having lots and lots of dental work needing to be done after treatment. The first thing to do is check with the oncologist if it's safe to have dental treatment and whether your white blood cells are back up to where they should be. Visit the dentist to have an assessment, touch base, and we can then look at what's changed after cancer treatment. Sometimes it's not a lot. Sometimes it's things have sailed quite through, especially if you maintain that oral hygiene and you had the right products in place. But in other times, I've seen situations where my patients have come back and things have changed. They've got decay in various areas where they previously were not a high-risk patient. So that's an opportunity for us to then treat any issues that have occurred and then look at what do we need to be doing long-term to keep that risk level of decay low. I can do fillings until the cows come home, and I really don't want to be, because ultimately it's reducing that disease burden for the patient. The other thing that I often chat to my patients about is how has their ability to clean changed. Sometimes having treatment might mean that their dexterity has changed, and we need to look at different oral aids to help them keep that cleaning level up. So I mentioned earlier about the risk of tooth extractions, and this is a really important point that I want to make. In some cases, the change that occurs during cancer treatment means that there is a higher risk for patients who have to have treatments that involve the jawbone. So things like dental implants and tooth extractions both involve a level of bone healing, and the ability of the bone to heal can change with some medications. So one thing that I want to talk to you about is MRONJ. So MRONJ is medication-related osteonecrosis of the jaws. It's quite an uncomfortable and a bit of a nasty complication to having a tooth removed where the socket or the bone that the tooth was housed in doesn't heal. And you have a section of the jawbone that becomes necrotic or it dies. And the treatment for this is not pleasant. In some cases, it involves surgery to remove the section of jawbone that has died. And long term, it's much, much better to try to prevent it than to treat it. So some medications that we know have been involved with a link to this are denosumab and bisphosphonates. there's a well-documented link that these medications put their patients at risk of developing MRONJ if they have to have a tooth extraction. More notably for cancer treatment, there are some anti-angiogenic drugs which have this link, but the evidence is still emerging. So we as dentists are sort of watching this space to know which of our medications that our patients are being treated by puts them in a risk for having teeth out. The blanket rule that I would encourage everyone to follow is not be in a position where you need to have a tooth out if you can. The second complication is ORN, and this is more associated with patients who have had radiotherapy. I will preface this slide by saying that this is a low-risk situation. It's not going to be par for the course for everyone who's had head and neck radiotherapy. And what this slide is showing is that the types of cancer listed, most of them are in the oral and oropharynx region that then end up developing ORN. But brain tumours come under others, and whilst it's a very small risk, it's still there. And you don't want to be in a situation where you need to treat this issue because it's quite a difficult thing to treat, and nobody wins. It's not a good situation. So the take home is to avoid extractions if you can help it. If my patients come in and they've had cancer treatment, particularly head and neck radiotherapy or chemotherapy with some of those afflicted drugs, my last course of action will be to pull the tooth out because it's risky for them. So the take-home message: before starting treatment, if it's practical, always see the dentist. If there's a tooth that looks a little bit dodgy and it's probably not going to benefit to keep it in the long term, get rid of it before you start treatment. During the treatment, try to keep the mouth moist, try to maintain some oral hygiene, and boost your own defenses by getting some high-strength toothpaste. Chat to your dentist about which products are going to be best for your situation. And afterwards, maintain good hygiene and see the dentist regularly. If small issues are cropping up, we want to nip them in the bud, because if it becomes out of hand, tooth extraction starts to become our only option, and it's high risk. So we want to nip things in the bud before tooth extraction becomes involved. And that's about it. Any questions, guys?
Thanks, Al, that's great. Any questions? No?
With jaw necrosis, once you've had the operation, tooth taken out, and you have to have surgery, what do they replace the bone with?
They don't. They don't. We usually try to manage the situation with a team of oral maxillofacial surgeons. So what will happen is we will assess the tooth. If it's deemed absolutely necessary that the tooth has got to come out, and I mean we'll be fighting tooth and nail to not remove it, we will be working with an oral maxillofacial surgeon to remove the tooth. There are certain ways that we can remove the tooth to try and minimally traumatize the bone, so there's not a lot of healing that needs to be done. And during the healing phase, sometimes we will flush the area with antibiotics and get the patient on hyperbaric oxygen to try and get a smooth healing process. But I can't stress enough that it's not a good idea to put yourself in that situation if you can help it. If you have to have a tooth out, speak to a dentist and we'll sort of discuss the different risk levels. And oftentimes there is an option that involves perhaps treating a tooth conservatively. You might not get a full tooth to use and it might not be a functioning tooth, but it's better than having to have it out. So there is sometimes an option to just keep it in there. You're not necessarily having good use out of it, but it's at least not being removed.
Yes.
In these instances, would you be recommended to see like a specialist dentist, or would most dentists sort of have this knowledge base and be able to develop that?
Most dentists will have this knowledge base. most dentists, if not all, will be involving a surgeon if a tooth needs to come out. But in my practice, my philosophy is to try to be as conservative as possible in my management. So if there's something I can do to stop that patient needing surgery, that's the goal. Yeah, sure.
You mentioned in one slide the spit don't rinse.
Yeah.
If, for example, someone's using that really high strength toothpaste, should they be rinsing before they eat or drink, or should be fine, there's no room?
For an adult, no risk, right? For children under 12, I don't recommend that toothpaste anyway.
Yeah.
They should be on 1100 parts per million, which is like like a Colgate Total or a McLean's or something. That's sufficient for them, and generally that paired with good oral hygiene, like maybe a bicarb rinse to get the acid low, is going to be sufficient for them.
I might ask the last question. You seem like a lovely person. I really like to go into you.
But I'm a dentist.
but I'm assuming, a lot of people don't like going to the dentist.
Nobody does.
And I'd imagine after, during therapy, many of these patients have been through the ringer. They've seen so many healthcare professionals, and the last thing they want to do is be seeing another healthcare professional. So how do we get, because this is clearly very important, so how do we get patients to go to the dentist? Is it the carers that need to be informed? Is there a process during the therapy where the patients are informed and the carers are informed about the importance of this?
Yeah. That's actually a fantastic question. And more, so I am affiliated with the Australian Dental Association, and we work closely with the Australian Medical Association. So we are trying to get this to be par for the course, that when your GP is discussing with you the various people you need to talk to and the things you need to do and whatnot, dentistry is there among them. And as in my personal anecdotal experience, a lot of my patients have been referred through the GP pathway to get this issue sorted beforehand. So we normally do a screening, we make a list of these are the issues, and generally your dentist will say, these are the issues that are low risk and we're going to deal with them afterwards. These are the issues that are high risk and we need to be treating them beforehand. So really, to answer your question, Stuart, it's everybody's responsibility. It's the carer's responsibility. It's the patient's responsibility. And more than that, it's the primary healthcare provider, the GP's responsibility. Generally, if you're usually seeing the dentist anyway for your 6-monthly checkup, you would mention to them that, listen, I've had this diagnosis, I'm looking at this treatment, what do I need to do? And the dentist will know that this is the time to screen. This is the time to nip things in the bud.
Another question. I just want to say, from somebody who's been through the whole system and just the envelopes that are in the foyer with information, because a lot of people been in the health industry for a long time, it's too overwhelming.
Yeah.
So to me, it's very simple. So when you are diagnosed and you have all the people coming in the hospital, blah, 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 there can be a dentist brochure that people take home, and that's what they have to read. It has to be very clear for everybody in the community. We never knew about dentistry, and having a glioblastoma, well, not me, my husband, that would be the last thing I would have asked the dentist. So
Absolutely.
It needs to be a very beginning.
And that's fantastic. Like, I will take that back.
That's all.
Yeah. That sort of feedback is very important to us as an association, because we need to see where the gaps are.
And it has to be in pictures, and it just has to be very simple. Ask the questions, and if this happens, go, these are the questions.
Yeah.
These are 5 questions you should be
Asking.
Just simple, very simple.
I've been a carer for 14 years, and I didn't know about dentistry until earlier this year. And I'll speak to you after, because my husband currently needs a lot of extractions and a lot of fillings. So I didn't know anything about dental, but please, everybody,
Go to the dentist.
listen to the dentist is very important, because at the moment we're going to go through a really tough time with
6.
it.
Wow.
Yeah.
That was pre-chemo or pre-treatment or
It's
just...
been how many years? No.
2008, Dustin's had 3 lots of radiotherapy and 12 months of chemotherapy, and just this year I had no idea about dental.
No
Took him to the
pain.
dentist. Should I say the numbers? He needs 6 teeth removed and 11 fillings.
Yeah.
And
Yeah.
right now,
And that's not your fault, you know, that's not your fault. You're doing your best with the information you have.
I didn't know about dental until just now it's become a disaster. So this is very serious.
And just a brochure. That's all. Just something.
Noted.
It's very important.
There was just one other thing for me. I did read up on all this, and as soon as I read osteoporosis jaw, by taking the medication for it, the bisphosphonates, whatever, I chose not to take it.
Bisphosphonates, yeah.
Yeah, because of that osteoporosis of the jaw, I didn't want to get that. Even though my teeth are fine, but I've been through chemo and stuff. But it's the bone.
It's the bone. And I'm more than happy to chat about this afterwards because I don't want to take up too much time. But the take-home message there is we need to manage risk. So ultimately, if that medication is going to benefit you from an overall healthcare perspective, you should do that. But it just means that the lens with which your dental care needs to be managed is much more preventive. We just want to nip things in the bud very early so as not to put you in a position where you need to have a tooth extraction. And a lot of my patients, I'd say 20% of them, because I work in a demographic with a lot of older people, have these issues and we manage them just fine. We just need to be aware.